Raghu,
I feel like
how is the COVID thing in Manipal?
in Manipal it's not too bad.
Okay.
But generally, I think in India there's a surge in COVID cases.
Very much, yeah. Everywhere actually. Not only in India. India it is probably the worst.
But I think
But
the subcontinent
USA, I think USA is doing better than what it was.
Raghu, do you have access to YouTube?
Uh,
I have a feeling the sound is not there.
you want me to check if there is sound on YouTube?
Yeah, if you can. Because
When you
somehow.
logged in, Dr. Mandana, when you logged in first, there was some music, by the way.
Yeah, I have access. I have logged in.
Okay, just check it, but I don't think it's playing there somehow.
No, I can hear you.
You can hear me on YouTube, right? Okay, cool.
Yeah.
I think we'll just go on. Yeah.
1 second. What I'll do is I'll just.
You can hear me, right? On YouTube? Okay, let's just ask everyone on YouTube. Hello, folks. Can you all hear us?
I can hear.
Yeah, okay, it's clear. Okay, cool. Yeah, we can go. Okay, sorry, everybody. Right. So, greetings and welcome to another live stream by Oral Pathology India. Our regulars will notice a change in the starting, a little less PowerPoint and a little more FaceTime, although we had a little bit of a problem. So constantly changing in search of perfection is human nature, and we will keep on until we reach it. Today we have been with oral precancer, constantly adding, removing, changing, and renaming entities in what seems to be an unending saga, because we have not reached that perfect level of understanding where we can prevent the lesions from becoming a cancer. Now, in this, sorry, okay. This time on the, sorry, okay. The ongoing battle, we cannot afford to forget the lessons of the past and the insights of the present. Now, here today, we have with us Dr. Jerry Bouquot, who's going to share a journey of 180 years of oral precancers. We are absolutely privileged to have the world-renowned expert and most generous and kind oral pathologist, Dr. Bouquot, with us. Welcome, sir, and thank you for joining us.
Happy to be here.
Thank you. Lovely.
My honor. It's my honor, truly.
Thank you. We also have a global panel of experts, Dr. Daftari and Dr. Hazare from India, Dr. Tilakratne from Malaysia, Dr. Nasir said-al-naief from the US. And moderating the session today is another expert, Dr. Raghu Radhakrishnan, Professor and Director of International Collaborations, Manipal College of Dental Sciences. Welcome, everyone. It's wonderful to have you here. And with this, I shall take a break and hand it over to Raghu. Raghu, please start.
Thank you, Dr. Vandana, for that kind introduction. I have the honor of introducing a luminary who is the epitome of sincerity, smartness, and success. He has trained at the University of Minnesota, the Mayo Clinic, and the Royal College of Dentistry in Copenhagen, Denmark. For 28 years, he chaired diagnostic science departments in 2 dental schools. He has been co-author of the most popular textbook of oral pathology ever, and has been president of the American Board of Oral and Maxillofacial Pathology, a senior visiting scientist of Mayo Clinic, president of 2 national oral pathology organizations, and director of American Cancer Society's National Board of Directors. He has won more than 61 teaching, service, and research awards, including the St. George Medal, the highest award given by the American Cancer Society, the Distinguished Alumnus Award from the University of Minnesota, the Lifetime Achievement Award from West Virginia University, the Distinguished Dentist Award from the West Virginia Dental Association, and honorary diplomat status from the American Board of Oral Medicine. He is now retired as an emeritus professor of the University of Texas, but is clinical professor of West Virginia University, and remains the director of research for his 28-year-old private research center, the Maxillofacial Center for Education Research. He has been the director of two of the largest US oral pathology biopsy services, one of which routinely receives tissues from 45 states and 5 foreign countries. He has been awarded the fellowship by the International College of Dentists, the American College of Dentists, the Academy of Dentistry International, the American Academy of Oral Maxillofacial Pathology, the Royal Society of Medicine UK, and the Pere Fauchard Academy. He has been on the scientific advisory boards of 5 US and European organizations. He has published more than 415 papers, abstracts, and book chapters. His precancer, oral disease epidemiology, and bone research has been cited more than 17,000 times. His Bouquot to-go Dropbox files are the most popular oral pathology files on the internet and provide more than 3,600 copyright-free clinical and microscopic oral pathology photos. Ladies and gentlemen, it's with greatest reverence and adulation I am delighted to present the greatest leader of our times and a legendary oral pathologist, Dr. Jerry Bouquot. Over to you, Professor.
You forgot, Raghu, to say that I'm missing a tooth. I should explain that to everybody. I have an implant here and I was supposed to have the crown placed last week, but the dental assistant got COVID, so they had to shut down the whole clinic. So I come to you with a nice bright red face I can see, and that's not the way I normally am. That's just the lighting I have here. So those are just my first few flaws. I'd like to, first of all, thank you for inviting me to do this. I actually had a lot of fun putting this together. You don't know this about me, I don't think, but I discovered in my early years in West Virginia University, even though it is a university in a poor state, it had without a doubt the best dental journal library I've ever seen. And I'm talking about comparing it with our National Medical Library even. And so I decided, since I was on the library committee, they said I could take these books out and keep them in my office. And we're talking about books that were journals that were published in 1839. And so I came in an hour early. Nasser, you were talking, you're very early where you are now. That's when I started getting to my office at 6 in the morning, just so that I can spend an hour reading literally page by page all of the old dental journals. Those people, they were mostly physicians at the time, of course, but they were phenomenal. They knew stuff and they did stuff the way we do it today. They just didn't have any proof that it was a good thing to do. So it is my kind of personality to really enjoy the history of dentistry. And then, of course, oral pathology is my special love. So this has been a really fun topic. I have to admit that I probably will not finish my talk because I never finish my talks. And Raju or Mandana, you're going to have to just hold up your hand and say, stop, time's up. Please feel free to do that. So let me share the screen. I wanted to say that in my ripe old age, I have come to more and more appreciate the mentors in my life. And Bob Gorlin and Dave Darlene at the Mayo Clinic, he was a bone pathologist, and of course, Jens Pinborg. They all became good personal friends, but when I was their mentee, they also gave me as much time as they possibly could, and they had my best interests at heart. And so one of the quotes that Dr. Gorlin in Minnesota used to say all the time, if you hear the running horses, they sound exactly like running zebras. To tell the difference, open your eyes. And it's a simple quote, but really what he was talking about is we're pathologists. We're supposed to look for the most odd thing in whatever we're looking at, clinically or microscopically or in a research setting. So we are trained and required to see the zebras in everything. That doesn't mean we diagnose zebras all the time, but we have to know all about them. And one of the standard things, one of the things that really has gotten oral pathology accepted by the world of medicine in our country was the odontogenic tumors. And the medical pathologists back in the 40s and 50s when we were starting, they were just too confused. They didn't want to have anything to do with it. So they were happy to have some people around who could help out. But the background thread throughout all of our history in the US really has been oral cancer. And perhaps it seems strange now, it certainly does to me in this country. Oral cancer was not considered to be the purview of the general dentists in this country when I went through dental school. We were not expected to do oral exams. We were expected to take care of the teeth and the gums. And that was pretty much it. So I'd like to just go through some of this history. And I'd like to also point out Ashley Clark is a really good friend of mine who taught here at West Virginia University. And she was teaching here when I came back. And she is probably the best of the young oral pathologists. But we decided to put a law together for our students. The Bouquot-Clark first law of diagnosis is look for the abnormality, and your dental hygienist can say, look, that's abnormal, but you're the doctor. You're supposed to say that's abnormal. Here's a list of things it could be. And that takes a lot more knowledge, not intellect, but information. And then, of course, as time went on, we ran into things that we didn't know, didn't have a name. So I gave it names. Right now, I'm up to 39 different entities that I've named or renamed for a couple of those early ones. But we didn't run into things that just don't have a name and nobody's ever talked about it. So we still had to deal with it. So those are our laws. And I want to point out the fact that Dr. Mandana, she and Raghu both have said kind things about me and my reputation, but I don't think that they realize that they also have a very high reputation over here. And one of my very best friends is from Sri Lanka. We have done so much work together. I was his chairman down in Texas, and Viggy was kind of taken aback when he moved to Texas. He was called Vicky. That's how all of us called him. Vikneshwaran is his first name. And he got to Texas, and the very first thing somebody said is, you cannot come to Texas and be called by a girl's name. So ever since then, he's been called Viggy, V-I-G-G-I-E. But he was the very first oral pathologist in this country to be trained in immunohistochemistry. And he has continued that research, that type of research, forever. It's one of the most impressive people I have ever met. Well, just a quick talk about how I got into all of this. Looks like I misspelled my son's name. We have a lot of Boucots in the picture, including my wife and my mother. This was when I was a resident. Having a child as a resident is pretty challenging, but in retrospect, it was wonderful. I got into this whole business of precancer because of Bob Gorlin. He didn't tell me all the facts. What he did was he called me in one day, and first year of my residency, it was a 3-year program. And he said, I think I've got a project for your master's thesis. And I said, oh, sure, what is it? And he said, go and learn about oral precancers and leukoplakia. And I want you to know about prevalence studies and incidence studies. And we had very little of the epidemiology in our school at that time. So I had to take a whole bunch of courses in the School of Public Health at second semester, just so I knew what I could say. But as it turns out, he asked me to abstract the data from looking at a bunch of oral mouths in adults. And it turns out that this was a series of 17 screenings. They called them oral cancer screenings, but they represented over 70% of all the adults in those communities where they did the screening. And every lesion was identified by an oral pathologist with clinical experience. Minnesota was almost the only school in the country where oral pathologists were actually seeing patients at the time. So we were pretty well, we were pretty knowledgeable in that arena because of Bob Gorlin. So at least we could trust the diagnoses. And also, if we felt it should be biopsied, we had oral surgeons there to do the biopsies. And we biopsied about a fourth of all the lesions. So it was my introduction. And it turns out the reason that the university set this up with the state government, the public health department, was because they wanted dentists to get it into their heads that this is something that dentists are supposed to be responsible for. They should find the early cancers and they should find the precancers. And we did a lot of continuing education for all the dentists who participated in this group. And it was way more work than I ever thought was possible. And that was back in the days when we had punch cards. And we would put punch cards into our computers. So it tells you how far back that goes. But all in all, even though it was a huge amount of work and I put in many all-nighters, it was a worthwhile endeavor. And we got some really good data because of the way Gorlin set it up. All the lesions, this was published right after I left my residency. I went to Denmark to study with Jens Pinborg for a year. And then after that, I had another fellowship from the American Cancer Society to go to the Mayo Clinic to study bone pathology. So I didn't have time to publish my research. And then when I started teaching, I was so busy teaching, I had no time for anything at that point. So I didn't publish my master's thesis, I think, for about 12 years after I graduated. But it turned out it was a good move. And these are the prevalence studies that were around at the time that I was doing mine. And the latest one that came out of the 1900s was Prout. She asked me to model that for her from some free clinics in Boston. And she had about 5,000 students. But the biggest one of all, it was here in America, but it was in young men. These were recruits into our U.S. Army, and all of the diagnoses were made by general dentists who mostly were relatively new out of dental school. So I'm not sure we can trust the diagnoses all that much. And of course, you'd expect since they're young, they found very little leukoplakia. It turns out that about the same time that I was doing my research, Tony Axel, an oral surgeon from Sweden, decided that was doing his research, and he had 20,000 adults. And of course, in Sweden, they have socialized medicine, so all of the records were readily available. So his actually represented every adult in those communities, 20,000 individuals. Mine represented about 70%, and altogether it was about 25,000 individuals. But look at where we ended up. Almost identical, the same proportion. And this was the first real proof that we had that oral leukoplakia is a pretty big deal in our practices. And these numbers go up, at least in my study, they were up to 8% if you looked at people over 70 years of age. And of course, this was a time when everybody was smoking, and in Sweden, they were chewing a lot. And it was also at a time when leukoplakia and smokeless tobacco keratosis were considered by the same name. So In our study, I know we separated out smokeless tobacco, but I don't know if Tony did. So that seems to be where it was back in the 70s. And Pinborg was one of the first people to really start doing the epidemiology studies, in incidence as well as prevalence studies. And he came from a little country. I think at that time, Denmark had no more than 5 million people. So he did a lot of his studies in India, as you are well aware. And a lot of his studies were not only prevalence studies, where we found prevalence of especially smokeless tobacco and oral cancer, but they were studies that had to do with follow-up. They had people come back, and sometimes some of his studies were 10 years of follow-up. So valuable, probably the most valuable thing you could ever do to something that we consider a precancer. And so he did his precancer work a lot in India, others in Southeast Asia and the Pacific Islands. And he was always gone. I know that when I studied with him for a year, he was gone about 60% of the time. But he really was interested in this sort of thing, and it became a passion for him. We had, if you look today and find out how many frequency or prevalence studies are published, at least in the English language, no, I guess in any language, it's well over 800, pushing 900 by now. But the numbers remain pretty close to the same. And it seems to not vary very much between countries, unless we have a country like India, where the amount and the type, quality of smokeless tobacco use is so different from cultures such as we have in America. So that's how I got started. It was exhausting work. I filled out a bunch of my computer forms with my little baby boy on my lap. That was kind of nice, but it was a little tough. And I want to point out, I'm 8 years retired, and I retired when I was 70. And I should point out also that I look like I'm frowning all the time. I'm not frowning inside. It's just the way my face has fallen as I've gotten older and heavier. So please don't take that as an indication. Just look at my missing tooth and smile. But one of the things that has been most interesting, because I have been super interested in seeing a ton of oral medicine type patients, I've been able to correlate in my career, and was one of the first people to do so, correlate clinical impression with microscopic diagnosis. And I told you that I had 39 new entities that I had to give a name to because they didn't exist. And I know that if you don't have a name to something, nobody ever studies it. But I always kind of regretted that I didn't have an even 40, but I have an even 40 now. As of about a year and a half ago, a surgeon in Arkansas started sending TMJ studies or tissue to me to evaluate, and I have been finding tons and tons. It's over 20% of those cases of 100 and maybe 120 joints, about 20% of them have little bits and pieces or chorostomas of parotid gland. So there's always something new. This has never been reported before. I was the first one to report mucocellular glands, chorostomas within the marrow of the jaws. And it's kind of one of my ironies in life that my case number 40 is going to be something similar. Well, first of all, I don't have to tell this group that there are lots of different oral precancers in the mouth. As a matter of fact, I think we have a whole mix of precancers that kind of makes the other sites of the body look a little bit anemic. But this all started, and I'll get into the history in a little bit, with syphilitic glossitis. And syphilitic glossitis in this country, I know syphilis is common still in other countries, but very few people get into the third stage of syphilis here. Syphilis is becoming more common with the drug culture, but it is still, nobody gets into the third stage of syphilis, and that's where the oral precancers are. So we have, I think in the 4th edition of the Neville book, we even dropped syphilitic glossitis, or we just gave one little line comment to it because nobody's seeing it anymore. But when I started out, I saw several cases of syphilitic glossitis. It's one of the advantages of being old, I guess. I saw things when nobody else was seeing much at all. Also, we've known for a long time that if you have a vitamin B deficiency, that you are prone, this comes out of the Scandinavian studies from the 50s and 40s, actually. You, especially if you have a smooth atrophic tongue, you are prone to develop oral cancer of the tongue, and it's really more glossopharyngeal cancer. It's the posterior part of the tongue. Leukoplakia has always been the big one in our world. And my prevalence study showed that of all the precancers in those 24,000 adults, 80% of them were oral precancers. So it's worth spending a lot of time teaching this and trying to learn as much as we can. I consider proliferative verrucous leukoplakia, under whatever name you prefer to use, to be a separate entity, actually. It looks like leukoplakia, but it's sort of like smokeless tobacco keratosis compared to leukoplakia. They have different biological behavior, at least in this country, the way in this culture, but they're too different to be having the same name. And leukoplakia has an interesting definition, as you all know. It's white. You can't figure out the cause unless it's tobacco, and you can't give it another diagnostic name. That last bit is really unique. I think there are only 3 or 4 diagnoses in all of dentistry that have something like that. And so as leukoplakia is today, it's much more concentrated and true leukoplakia than it was when if we studied the leukoplakias in my early years. And it just so happened by chance that I was well aware. I read a lot of the studies from India from the early 1900s as part of my master's thesis workup. And so I was aware of the fact that the smokeless tobacco stuff is different. And I was one of the first, matter of fact, I think I was first to propose in India in a book published out of an World Oral Cancer Congress. I proposed that we get rid of the word leukoplakia for the smokeless tobacco lesions and call them smokeless tobacco. I just called it smokeless tobacco keratosis. And that seems to have caught on, and at least in this country, I think it's really made a difference because now we can study the lesions separately. Lichen planus was considered a leukoplakia when I was young. Smokeless tobacco keratosis, nicotine palatinus. There were lots of things that were included in leukoplakia over the years. And because of that funny definition, which I think is appropriate, we've changed the definition of leukoplakia as time has gone on. We're more down now to pure leukoplakia than we've ever been. And PVL is one of the reasons one of the reasons we can understand PVL better is we've had that mindset, that change. And then there's this thing that came out about 20, 25 years ago. It's got different names: atypical papillary, atypical verrucous, epithelial hyperplasia. We really haven't settled on a name for this, but we're starting to see kind of a lichenoid response in the tissue. And some people are considering it maybe a lichenoid version of PVL. And other people just recently have suggested that maybe PVL itself is a lichenoid type of dysplasia. I don't know about India, but in South America and some of Southeastern Asia, people roll their own cigarettes, and it's poor quality tobacco, so it doesn't stay lit. So they put the lit end in their mouth in order to control the air that goes across the embers. And we call it reverse smoker's palate. That's only in fairly, I hate to call them primitive cultures, but unchanging cultures. And it's not in any of the more advanced, if you want to call it, nation. It's just not a habit. It is a habit in marijuana smokers, but they smoke it. I've not seen reverse smoker in marijuana or heard about it. But because the lit end is in there, there's a lot of temperature damage as well as carcinogen damage. And in those cultures, the hard palate is the most common place for cancer to develop, whereas a hard palate is, at least in our country, we almost never see hard palate carcinoma. Oral submucous fibrosis I won't go into because you're much more aware of that than I am. Erythroplakia, one of the proudest moments I had in my career was when I was here in West Virginia and I was writing up an epidemiology study on erythroplakia of the whole head and neck area. And in my research, I discovered a paper in the 1950s, might even be late 40s, where it turns out my mentor, Bob Gorlin, was the first one to actually write about erythroplakia. He called it erythroplasia, but the same thing that he called it Bowen's disease also. And it just was a proud moment to realize that he was the guy who first wrote about that. And I won't get into all the others, but if you live in a country in a place that has a lot of sunny weather, you've seen a whole bunch of actinochylosis. And we haven't done these studies so much in dentistry, but in dermatology and ENT surgery, they have done studies that have shown that has a certain, actually sometimes relatively high cancer potential. Smokeless tobacco keratosis, I've already talked about. Lichen planus, believe it or not, lichen planus, when I saw a lichen planus patient as a resident, I got so excited because this was so rare. And now it's so common that it's just sort of boring to talk about it. But it is a very interesting part of our lives as oral pathologists and oral medicine people. There was a time when Candida was thought to be producing a cancer, but now I think the thinking, and it varies, not everybody thinks like this, but I think the thinking is now, there's a paper just last month, I believe, out of India, now, if I'm remembering right, that looked at Candida virulence and subtypes and treating Candida in leukoplakic lesions and trying to analyze whether the Candida was an improvement or not. And their conclusion was Candida probably doesn't stimulate doesn't increase the risk of, a precancer, but it certainly does make the epithelial cells look more dysplastic. And over here, we had sanguinaria leukoplakia back in the 80s and 90s. We don't see it, almost never see it anymore. And that was because one of our most popular toothpastes put much higher levels of soap, which sanguinaria is, into the formula. And we started seeing these things on the unattached gingiva. And some of them actually had dysplasia and a few of them went on to cancer. So I put a question mark after it. I don't know if we'll ever really know if that's a precancer or not, but it's probably a true leukoplakia. And then I don't think we can say for sure what the true frequency risk is, lifetime risk for these things. But for the textbook, I wrote the chapter on epithelial pathology, and I wanted to put in a chart to show that, hey, all of these lesions that we consider precancers, some are worse than others. And so I just put stars after them, and more stars are higher risk. And from that kind of thinking, I've come up with some numbers, but you can find studies that will make these numbers look kind of silly. But I don't mind being a little silly, but I think they're, at least in my heart, I think these are fairly accurate. And one of the neatest studies, there was just another one that came out 2 months ago out of Thailand, I think, very similar. This is a British study. Of course, they have socialized medicine there too, and have had for a long time. So they found, they took a bunch of patients in an oral medicine clinic where they knew they had the proper diagnosis. They had the biopsies of anything that required biopsy. And then what they did is they went into their national cancer registry and tried to identify people by those names and their national health number. And so the data was already there. Nobody had to follow anything. It was retrospective, but it was a true follow-up study. And the average follow-up time was 9 years. It's a really unique use of information that is available. I was very, very impressed with this. But out of the 204 patients, or 204 of these individuals had dysplasia, and most of them were severe or moderate. The mild dysplasia, there's even a question now in our literature about whether we should bother calling something mild dysplasia, but nevertheless, they used 3 categories, as I still do today. And this is the number they found. And out of that whole batch, what was the cancer risk? 2.6%. And if you look at the actual follow-up studies today, they vary anywhere. Some of them are up to 40%, but most of them are, this is maybe on the low level of this, but it's also lesions that you can trust the diagnosis of, rather than a bunch of general dentists looking at something and maybe not having the most correct diagnosis and then following something under the wrong name. And we run into that a lot over here with national and state studies. Well, the diagnosis matters a lot. Leukoplakia, 7% of the leukoplakias went on to cancer. Lichen planus, only 1% went on to cancer. And for the first time ever, somebody looked at lichenoid reaction, these allergic so-called topical reactions, and they found that actually the cancer risk was higher than regular lichen planus. And of course, they included all types of lichen planus, not just the erosive forms. So the number would be higher, I'm sure, for erosive forms. But still, that's something, and what was confirmed with another paper about smaller numbers of subjects, but about 6 or 7 years ago. So this other shows also that age matters. Lots of things matters. Age, as you get older, you're going to have a higher risk. Location is apparently super important. The floor of the mouth was so bad, and ventral tongue is so bad that those are the 40% cases that we talked about earlier. And in England, back in the 50s and 60s, they were calling these sublingual keratosis, and that was the highest risk leukoplakia that they knew of. So location is very important. And on the tongue, whether it's on the ventral or the dorsum, we almost never see leukoplakia over here on the dorsum of the tongue. So I'm assuming most of this was ventral. And then this is where we are right now. We're trying to come up with all kinds of immunohistochemistry, genetic mutations and things of that. And in precancers that will predict what is going to happen, what the risk of cancer is, but nobody wants to follow these people. And so they're using the dysplastic level and saying, well, this is higher in severe dysplasia than in mild dysplasia. Therefore, this is associated. This change is associated with a cancer risk. And I can't argue with that, but that's not the gold standard that we should be using. Eventually, those follow-up studies will be found or done. And what they found in this study is as you get into the higher levels of dysplasia, you get into more and more risk of cancer. And severe dysplasia is more than 1 in 4 risk of going on to cancer. So nice study. Samam was the one who did that. He's one of the most impressive people I have ever run into. He does some really great stuff. Well, we also, over the most of the 1900s and with confirmation in this century, we found out what caused cancer. We've always kind of thought that tobacco was the reason. And in the early years, that was 70% of the cases. In our country, we're down to 15% tobacco chewers or tobacco smokers. So the whole character of leukoplakia has changed because we've had that funny definition, but it's also changed because the ones we're seeing are in non-smokers more than the smokers. We don't know if marijuana or vaping or hashish use is going to be a problem. There's a little hint that these have some precancerous potential. We certainly have carcinogens in their smoke, but we haven't got any follow-up studies, just a few case reports. HPV, I got the first NIH grant for HPV research, a look at leukoplakia, HPV 16 and 18, and it did correlate well with the level of dysplasia. That was back in 1989, I believe. And unfortunately, it was my first lesson that technology is moving really rapidly. 3 years after the study, after we started, we were ready to publish it. We realized from the literature that the technology we were using was too primitive. There were too many flaws in it. And so we never did publish that. And other studies with more sophisticated, more modern techniques have found the same same thing in some cases, and some papers have found no correlation. Syphilis we've talked about, Candida we've talked about, sun damage is kind of a no-brainer. Autoimmunity, increased age, we're not sure what the mechanism is. I'm not sure if you went into this, but for a phase in the 70s and 80s, the ENT people were looking at white patches of the buccal mucosa as leukoplakias. And it was really because these were in patients who were not well off. There were a lot of charity cases, and they were not brushing their teeth very well. And to not have bad breath, they would get free bottles of Listerine from homeless shelters and things, and they would use Listerine all day long. And it was simply a chemical burn of the buccal mucosa. But they thought they were biopsying it and sometimes surgically removing it. I think all that is past us now. Sanguinaria, I've already talked about. Chronic trauma, I had to make up the name frictional keratosis. It's the same problem with smokeless tobacco keratosis. You can't call a white patch leukoplakia just because it's a white patch. And if we have another name for it, like a callus or frictional keratosis, then we don't have to bother with that whole issue of is it leukoplakia or not. So if we know that it's chronic cheek bite, for example, we don't bother with biopsying it or thinking of it as a precancer. We just call it frictional keratosis and leave it at that. And frictional keratosis has caught on pretty well also. Some people have oral cancer, oral leukoplakia running through their families, but not too many. And we still have a lot of idiopathic lesions, and I prefer to think of myself as an idiot pathologist and things like that. And look at what's happened in just my career. Nicotine palatinus was a precancer. Now we don't think of it as that. I should put down chronic trauma when I first started was from a loose denture, was considered a precancer. And by the time I finished my oral path residency, neither this or that one or nicotine palatinus were considered precancers. Lichen planus came along big time. But we found out that it was only the erosive ulcerative types of lichen planus that were the risk factors. So the non-erosive forms got tossed out as precancers. Frictional keratosis, smokeless tobacco keratosis is not a leukoplakia. It's still considered to be a precancer. And then Listerine keratosis, I've just talked about. We have some new things added as we've learned. I've been kind of amazed. All of these names came out of the 70s and 80s, maybe a little bit into the 90s. And what we're doing is confirming. It's like my reading those old guys from the 1840s to 1870s, all that dental literature. They weren't so far off from what we were doing. It's just that what we're doing now is proving that our ideas are correct. So we have some new things out there in the world, and we've also come up with some false things. Sublingual keratosis, we decided to throw that name out entirely, and we just call it, most of it happens to be proliferative verrucous leukoplakia. Hairy leukoplakia, they knew it wasn't a precancer when they named it. It was named by a dentist with a PhD, but not an oral pathologist. And I think it's okay as long as the rest of us know that this is not a true leukoplakia. So how did we get started? First of all, we had to find out that we had to realize that if it's not pink, it's some kind of pathology. And much of pathology, mucous membrane pathology, is dealing with this. And the precancer concept, if you do a lot of reading and a lot of esoteric reading, as I do, you'll come across a paper like this in a medical journal. I think it was a British medical journal. In 1806, a committee of European physicians got together. They met in Edinburgh, Scotland, and they came up with a definition. They were concerned that there are lesions that are benign, but have a high risk of going on to cancer. So they came up with a definition, an alteration in the surface of a part. They were talking mostly about clinical things, preceding that more obvious change, which is called cancer. And their impression for most of the 1800s was if you had a precancer, you were guaranteed to go on to cancer. It wasn't until the ENT people started doing throat cancer, precancer, leukoplakia studies that we kind of changed our definition in the 1920s into something that meant that it was a precancer had a higher risk. You weren't guaranteed. Well, look at this. I read a paper from 1870, and Sir James Paget, one of the most famous of all the British surgeons, he was talking about things that go on in the mouth and things that might be responsible for tobacco. And in 1870, in that paper, he talked about ichthyosis, like fish scale thickness, ichthyosis of the skin. And I think from that description, he was talking about syphilitic glossitis at that stage. And that was a few years before the word leukoplakia was even invented. But in there, he also said, 20 years ago, I saw somebody, and he was a heavy pipe smoker. I saw several people. And so I called these white patches smokers patches, or leukokeratosis. And leukokeratosis was still a name that was in use when I was a resident. Yeah, he was, if you don't know how important he was, he and Virchow were the two pathologists that really are the fathers of modern pathology. I changed something here. And now your pictures are right in front of my screen. Sorry. So I will have to, you won't see me moving around, but if I'm hesitating, I'm just moving your pictures away from the words. We had in those dental journals, I kind of browsed through them after I read everything up to 1875, and then I just browsed through them to find oral lesions after that. And I couldn't find any precancer discussion. There were in the medical journals discussions about leukoplakia after it was first written about. And I think, I didn't press the right buttons for this slide. The very first use of that name, as you're all well aware, was by the Hungarian dermatologist Schleimer. And he did know that it was a precancer, and eventually, by the end of that century, it was considered to have about a 1 in 4 risk of going on to cancer. So he was there, but it was really Sir James Paget that had the first discussion about these white patches from tobacco. Nothing in our literature, but the ones that were in the medical literature were pretty much all German articles. I had to learn how to read German for my residency, so I read those. I don't think I can read German anymore, but there was one that was significant, Goodall in 1888. And it was in the British or the medical journal that now is the most prominent of all the pathology journals in this country, the American Journal of Pathology. It had a different name back then, but he called it hyperkeratosis lingualis. And actually, I think he was talking about hairy tongue. He had very detailed description, and I think it was hairy tongue, and there was a hyperkeratotic median rhomboid glossitis. So that really wasn't a good description. But later on, just a couple of years later, he had a true description of leukoplakia with a little bit of dysplasia in some of the cases. So this was, I think, the first microscopic description just at the turn of the century. And how far have we gone from there? we still have trouble coordinating the diagnoses between oral pathologists. Well, if we look at what happened in the 1800s or the 1900s, we can see that the first paper, and I remember again feeling really happy to have found this paper for my thesis. Fells from England, he was in London, he was in India at the time, but the paper came out in 1908, and he wrote about cancer and chewing tobacco and the risk in the Indian subcontinent. I think it was in Bombay at the time. And he discovered that he went around to all of the community hospitals there, and in their outpatient clinics, 72 to up to almost all of their patients had oral cancers. And he was just putting the word out there that, hey, there's something serious, something really different going on. And we should look into this because we might find some information about the biological behavior of these cancers of the mouth. Rubin, the first dysplasia definition or diagnosis was Rubin, but that was for the cervix. And believe it or not, I gave a talk once on tobacco effects on the mouth. And right afterwards, the grandson of R.J. Reynolds, the big tobacco company, the guy who founded the tobacco company in this country, the grandson was speaking next, and he was an anti-tobacco person, and we had supper together. And he told me his grandfather actually started mass producing cigarettes as a health feature, because everybody was spitting on the sidewalk and on the floors in America, and they were spreading tuberculosis, and that was the big disease at the time. So even though we considered cigarettes to be part of the devil's activity, that's not the way Mr. Reynolds initially thought about it. And then, believe it or not, a guy named Bloodgood, in one of the first journal articles from the Journal of the American Dental Association in 1915, one of the first physicians to write in that century, he was asked to write an article on oral leukoplakia, and he did. And he was pleading with dentists to please take over this responsibility of identifying these before they become cancer, because physicians never see them. He even made a statement saying he has seen more ranulas than he has seen leukoplakias. And this was the drawing that he made, that he put in that article. To me, that looks like a papilloma. Maybe it doesn't look like it to you, but this is his this representation of a leukoplakia. So I think he misunderstood a little bit what that was all about. But in our culture, in 1928, Ewing, another famous pathologist, was the first to say that chewing tobacco causes cancer in the area where the tobacco is kept. Remember, Fels said it much earlier in the Indian population. And then the first series of leukoplakias was in 1931. So it's almost a century from the time when people were first putting serious articles about leukoplakia. And one of the things that made a huge difference in the world was describing. We started to describe the clinical features of this. That was in the 1940s. And then Pinborg, he's the one who essentially brought the rest of us kicking and screaming into this concept that the clinical appearance of leukoplakia is super, super important. And there was a study from just, I think in February, that came out. Trying to think, that may have been in India. No, that was from Denmark. And they were correlating the clinical, the risk factors. It was a follow-up study. And the clinical appearance of the leukoplakias had a stronger correlation with cancer development than the microscopic dysplasia level. That's going to cause a little bit of a ruckus, but that's where it all started here in the early 60s with Jens Pinborg. And he's the one who said that leukoplakia goes through a series of phases. It doesn't start out as bad leukoplakia. It starts out as really pretty decent leukoplakia. Saul Silverman, an oral medicine doc in this country, was probably the premier oral medicine doc throughout most of his life, but he was the first to try to give some chemical treatment for leukoplakia. He used vitamin A, topical vitamin A, as well as systemic vitamin A, and it worked a little bit, but people are still trying that. Just 3-4 years ago, I read a paper about that. The first major study of leukoplakia in persons with oral cancer, where they said they took a bunch of people with oral cancer and then looked for leukoplakia elsewhere in the mouth, was because of Pinborg's and Silverman both influence. And so that was only in the 1960s. Tony Axel, the fellow who had the other prevalence for his doctoral thesis out of Sweden, had the first prevalence study, the major prevalence study of leukoplakia. I've already talked about that. But we also, if you're going to call something a precancer, you can look for dysplasia. And you can look for these precancers next to or in the same mouths as people with oral cancer, but you really can't prove that they're precancers unless you follow them and then see, does the cancer develop out of the lesion or is it somewhere else? And so the first study of that kind was a Danish study by Reed Peterson, who did a lot of oral precancer studies. Kramer was probably the most famous of all the British oral pathologists, one of the guys who essentially started Oral Path there. And he tried, back in 1971, believe it or not, he tried to computerize the appearance of lichen planus and leukoplakias to see if it would correlate. He didn't do a follow-up study, but he was looking at dysplasia. And it didn't turn out all that successful, but there's still, there is a paper from this year already that's doing something similar in a more sophisticated way. And of course, in 1974, I came along with my prevalence study. And this was a really big deal. In 1978, I think they met in England, maybe Denmark. A group of about a dozen people were asked to come together by WHO and talk for several days about all the oral precancers. It was getting too confusing. They wanted to make some sense of it. So they came up with the names that we used for a while. Some of them have been changed over time. They came up with definitions that we would use. And it was a really, really giant step forward. And only because we had some information that would help them to make those decisions. And in 2000, and let me move your pictures. This was 2005. We had another one. There was one in the mid 1990s, and then this would be the third one. And I was selected to represent North America at that time. Only about 8 of the people here were actually part of the officially invited committee, but that's the rest of them they just wanted to be there, and they really contributed a great deal. But isn't it ironic? We are now talking about committee meetings, and I kind of tongue-in-cheek joked about the first precancer discussion was a committee meeting in London. So here's another one. There was one just a couple of years ago, so all of this has been updated, and it really, we get the sharpest people going to those meetings, and it's really a wonderful, wonderful adjunct to our understanding. Whoop, sorry. I just wanted to let you know I'm used to those kind of meetings and hiding in the background. This is one of my family get-togethers. I grew up with six kids in the household. Well, we also had follow-up studies since tobacco was so highly correlated. What happens if you quit tobacco? So that's a big jump. And that was all the way back to 1982. And then Saul Silverman and Lou Hansen in California said they were scratching their heads. They did some follow-up of some patients with this verrucous type of very thick leukoplakia. It seemed to be moving faster than regular leukoplakia. And it did have a much higher risk. And for probably 30 years, the risk was considered to be almost 100%. Now it's somewhere between 50 and 80 since we've kind of become more sophisticated in making the proper diagnosis. But that was a huge, huge jump forward. Here we have they taking Pinborg's concept that different appearances of leukoplakia have higher risk. And then this was the ultimate. This was the highest risk of all. And then I started writing some of my Mayo Clinic incidence studies, and I came out with the first oral carcinoma in situ study. And also, it's not oral, but I came out with the first laryngeal keratosis. And I might add, by the way, the word leukoplakia was initially made for the tongue, and then we used it in the 1800s, and we kind of forgot about it. But medicine used it a lot for bladder, for the cervix, uterine cervix, for, the throat. And there were leukoplakia lesions in the literature up until maybe the 1950s. And then they decided to get rid of it. The cervical lesions aren't called leukoplakia, they're called HPV lesions now. And in the throat, that's called laryngeal keratosis. In the bladder, it's just called keratosis. So we are the only ones left using the word leukoplakia anymore. And I want to mention, I had a little bit of a dilemma. One of the new entities, we reported it first about 4 years ago, 5 years ago, is this. It looks just like that sanguinaria leukoplakia that I was talking about, but in this case, this is where this patient was keeping his powdered cocaine. And I initially wanted to call it cocaine leukoplakia, but we didn't know if it would go on to cancer, and I don't really think it is a precancerous lesion. So I did what medicine did, and I called it cocaine keratosis. And it's out there. I'm glad that it's out there because several other people have started studying it as well. And then we also got, in India, we had a 10-year massive follow-up of people who quit chewing. And I think that was one of the most impressive studies that I have ever run into. I think Pinborg was part of that as well. Oh, I should mention, back in 1989, when I just got my NIH study, Roy Ebersol and Bob Greer first looked at HPVs and leukoplakia, but I think they didn't know it, but they had the same problem I had. We had the very first PCR equipment ever made available commercially, and it had flaws. So we can't really follow their studies very well, but it did put up the red flag. People started to think maybe that's what the problem is. HPV is a cancer-related virus. Leukoplakia is a precancer. It makes sense that there would be a connection. And the connection is, I think it's there, but it's tenuous when you look at the research. And then, of course, I don't want to talk about precancers without mentioning the red one. Erythroplakia was mentioned way back in 1924, and he called it erythroplasia at the time. And he was also referring to it as a penile lesion. Erythroplasia of Coirat is how we pronounce it here. I have no idea if that's the way it should be pronounced. And on the regular skin, Bowen's disease is a term that was used for these red patches. And then Broders came along. He was at the Mayo Clinic, and he was the one who first came up with the cancer grading system using lip cancer. I don't know if you knew that. We used lip cancer as his model. And so we all, when we grade something or call it mild, moderate, severe, we are following Broders' path. But he was the first one to characterize carcinoma in situ of a head and neck site. And he was doing it pathologically, not clinically. And then Gorlin, it was 1950, I mentioned. I was really proud to see that Gorlin, because he never mentioned it once in the whole time I knew him. He was the one who wrote the first report of carcinoma in situ of the mouth with clinical features. And then right about the same time, Slaughter and his group came up with this field cancerization, which was very controversial. The idea was the whole head and neck area it suffers from the same phenomena. So the same kind of toxicities. And so all of the tissues are equally at risk. And that is very well accepted today. Well, I think let's see, probably running out of time or gone over time, but I just wanted to make one final comment. And that is the studies, the follow-up studies are, as I mentioned, as important. They're probably the most important to not only prove that something is a precancer, but what is the risk of cancer development. And these are the ones from the 1900s that had the biggest numbers of individuals. And my Mayo Clinic one was about 12%. That has a flaw in it because all of those are the records over a 50-year period of physicians who saw these and wrote the diagnosis in the chart. So it wasn't, the lesions were not found by dentists so much as physicians. But I would assume those would be the larger ones, the more ominous looking ones. So I would expect them to have a little higher risk. And but that number goes anywhere from 3% up to 40% in various papers. I consider lifetime risk to be around 4% myself, the whole group of individuals. And this was a patient I saw when I was, I'll go one more slide after this, I think. I was with Gorlin, I saw this patient. It was pretty obvious cancer, and histology proved it to be true. And then he came in to look at the patient and say, "Oh, I remember you." And he went back in his pictures. What made him famous was he took pictures of everything. And this was the same patient 5 years earlier. And he said, I could have told you 5 years ago that this was the area where the cancer was going to develop, because he understood that the clinical appearance of leukoplakia is very, very significant in risk. And the last thing, I gave the very first World Congress on head and neck cancer. I think it was oral cancer, run by physicians, ENT doctors, essentially. They invited me to talk about this whole precancer leukoplakia business. And after I gave the talk in Nice, France, I had some time on my hands, a few days extra, and I wandered around Nice and I sat on park benches, and I just thought I had all this information in my head, and I thought, how can I make this more readily understandable? So when I got on the plane, it was the very last Pan Am flight ever in the history of the world. There were only 6 passengers. Going back from Nice, France to the US, I started drawing this. I can't sleep on a plane, so it was an overnight flight. I started drawing it, and I ran out of paper right about here, and so I asked for some Scotch tape. And the stewardess, of course, there were more stewardesses than there were passengers. She gave me Scotch tape, and then she saw what I was doing. And finally, she came down with a board, 6-foot-long board, so I could put it across several tables. And overnight, I drew this out, and the circles represent dysplastic cells. And then I have a little bit of candida in here somewhere. So this is just an illustration that I've used with my students forever, and it's been in, I think it's a really well-known picture by now. I gave it to an artist friend of mine to make it look better, of course. But starting from the left, leukoplakia, and this is, I passed it by Pinborg, and he agreed with this thinking. It starts out smooth and thin, and then it gets thick and thin, thick and smooth. It may crack a little bit, become fissured because of all the flexibility in the mouth. But then the next step, the higher risk, is when it starts to get either verruciform or nodular, and then we even get more fissuring going on. And then the eventual worst phase is when the cells become so immature they can no longer make keratin. And so here it is in pictures, and there it is in drawings. And I think it's helped a lot of people understand. And actually, since the 1980s, I guess, when I drew this, our thinking hasn't changed. And I just told you a recent paper from just a few months back said that the clinical appearance was a better determination of risk than the dysplasia level. So with that, I think I will, Mandana, do I go on? Is it time to stop? I don't want to.
How many more slides do you have, Professor?
Maybe 4 or 5 more.
Yeah, please continue.
Okay. I like to bore people for long periods of time. Well, this is I wanted to talk a little more about this because it is the most intriguing thing. It's like when PVL first hit the scene, some people said that, that's nothing. It's just a made up disease. And of course, now we all accept it. But this is kind of a variant of a PVL, and the most recent paper looked at it as and was suggesting that this should be one of the variants of PVL. And they also agreed with my thinking. PVL is a different entity entirely, even though we can keep the word leukoplakia, and it's a different cousin to the main group of leukoplakias. There was a paper last year that came out that suggested this was a wraparound leukoplakia, because it seems to love to start here on the attached and marginal gingiva and then wraps right around the tooth. It doesn't push the tooth away. It doesn't do anything to the underlying bone, but it just makes, sometimes it even looks like a papilloma. and it's very rough on the surface. Here's one that has a little cancer in it, and the cancer has probably destroyed the tissue that led to this little diastema. I don't think that's part of the atypical papillary diagnosis, but I would love to live long enough to figure somebody will get a handle on this. There'll be enough literature and they have enough cases so that they can, number one, give it a better name, the best name, and also give follow-up. There is some follow-up of these lesions, but it fascinates me. And I'm just happy at my age to still be fascinated by anything. And the message that I give to general dentists wherever I go when I'm talking about oral precancer or just oral lesions in general is it's your responsibility. You have to find the cancers and you have to know about all the precancers, and you can't just look at it and say, well, that's abnormal. You can't nowadays in this country, you can't even look at a lesion and say, oh, that's X lesion. You have to say, oh, it's possibly one of these 3 to 5 things. So a differential diagnosis is part of what we require, if at all possible. Sometimes it's impossible. How do you come up with something other than geographic tongue? I mean, they all look so similar. So nevertheless, it's a dental responsibility, and I keep telling them, think below the surface. Think of those zebras. When you have a lesion that you know is a precancerous condition, think below the surface, because where you biopsy is going to determine how this thing is handled. And if you biopsy over here where it's thin, you would have gotten no dysplasia. If you biopsy here where it's rough and thick or non-homogeneous, as Pinborg called it, you would probably get some moderate or severe dysplasia, but here's where the cancer is, and you want to biopsy there. And then, of course, if you see any kind of bulging. So everything, it's like sharks. You see the fin, the precancers are just the fin above the surface. And then, of course, it's our job to look to see the surface. And this is essentially how we're still doing dysplasia. We're taking the lower 1/3, the mid 1/3, and the top 1/3. And then if it goes all the way to the top, we call it carcinoma in situ. This has been around in the cervical region since the 1950s. Of course, it does show that if we do pap smears, most of the things we do pap smears on in this country, we were doing pap smears like crazy when I was a general dentist. While I was a resident in oral path, I did about 20 hours a week of general dentistry to pay my way. But we were scraping these white things and sending them off for pap smear interpretation, cytopathology. And of course, we didn't find anything but mature keratinocytes. And that's what, back in the 90s, why we came up with this. We just jab this into somebody's lesion. We keep turning it until we see a little drop of blood, then we know we're through the epithelium. And then we toss it into a biopsy bottle, and the lab takes care of the rest. And it's essentially, at that point, a cytology smear. Doesn't hurt much. I suggested a master's thesis for a dental hygienist in our school. And the company cooperated and sent out the questionnaire to several hundred people, many hundreds of people, and quite a few of them answered. And their response was, no, it didn't hurt at all. They felt nothing. And only 4% said it hurt more than a pinch. So the idea is to get down deep, and it's a good idea, but this has lost popularity. We have lots of other techniques. Toluidine blue is going to stain the nuclei just like it would on my microscopic slides. And of course, if you have nuclei that are dysplastic, they're going to be larger. And they will, if they're closer to the surface, they will stain. And so logically, it's okay, but the problem is the mouth gets so much trauma. There are lots of areas where we've got big nuclei, maybe even close to the surface because it's been traumatized, and this is now an area of healing. So this never caught on. It was actually against the law because toluidine blue is a carcinogen. It is now acceptable because the company pushed the law out of the way, but it's not the best study. This is something very easy. Loss of autofluorescence is a way to go, I think. I used it for 10 years or so before I retired, and I wouldn't even really make a diagnosis interpretation of a lesion that I thought was a precancer without using one of these. And studies have shown that this will find areas where autofluorescence is gone, will find dysplasia right out to the edge where the autofluorescence finishes and normal fluorescence starts. And we have, this technique is FDA approved in this country for margins of pharyngeal and oral cancers. They can go out to the edge and the blackness in this scope and just cut at that margin, just a little bit beyond that margin. And it's a way to do more conservative surgery without, with a little bit of knowledge included. And we know quite a bit about this. We know what wavelengths, it's in the ultraviolet spectrum that we're looking at, and it's got a lot of good research behind it. I helped develop this particular one. This was a Houston company, and they deliberately designed it as a handpiece because we told them that's what we wanted. And it worked very well, but it didn't catch on in the market, so they don't have it anymore. And this is kind of where I'm going here. This is a technique, maybe when salivary proteomics gets more sophisticated, that a general dentist can just have a patient spit in the mouth and will diagnose diabetes, oral cancer, whatever. I think that day could come, but I've been waiting for it for 20 years and we don't seem to be any further along. We have a lot of good research data, but nothing that's of practical use in the office. So this is a practical technique. The equipment's a couple or $3,000. So it's a viable type of a product. But this is what we see. Here is a classic sublingual leukoplakia. It's got a little roughness, but most of it is smooth and flat. So, and I don't see much redness. So I would not expect this to be a very bad behaving lesion. I would biopsy in the area of roughness. That's about it. And the surgeon here outlined on the picture in magic marker the lesion. And it should be pretty obvious to all of us. But what happens when you put the goggles on and you hit this with blue light and you look at it through the Velscope or the Identify or any other autofluorescing device? You see that the area where the leukoplakia is actually pretty minimal. And the larger area, this was biopsied in 7 different places away from the leukoplakia. And it was just plenty, there was plenty of moderate and even severe dysplasia throughout this lesion. And right at the margin is where the dysplasia stopped. It's a pretty dramatic thing. It has some bad press from people who I think haven't really studied it very much. But if you look at this, you see a little bit of extra pinkness, almost like a erythroplakia, with just a haze of whiteness. And I don't think most people would have even noticed that, but this makes it obvious. And I'll end on this patient. She was young, been out in the sun, lived along the Texas coast for all of her life. And she came in because her dentist saw this little bump. And I said, well, how about the extra keratin and how about these red patches? And how about these up and down vertical lines? You know, I joked with her and I said, well, in my world, we associate that with being born with syphilis. And we had a good laugh about that, but it really is also a sign of people who have had sun damage, a farmer's lip or a sailor's lip, we call it. And the lip is puffy. It's bigger than normal because of her sun damage. And she said, yes, she was out in the sun all the time. Well, we used the Velscope on. I actually brought it to the dental office, the oral surgeon's office, to prove where the biopsies should be done. And we've got darker areas, less dark areas, but there were 4 areas of loss of autofluorescence. Maybe they're inflammatory. We biopsied those sites. And we found out that they all had dysplasia. The arrows point to mild dysplasia, and this one that was darkest red clinically, not darkest red, but darkest brown or darkest black with the autofluorescent loss, was moderate dysplasia. And so she had a lip strip procedure, and we prevented, I'm pretty sure we prevented a cancer. I would assume with this kind of information, she had at least a 40% risk of going on to cancer. So there it is. I just want to point out, again, reiterate Gorland's idea that we're supposed to look at the weird things, but also we have to see through all of the, we'll call it garbage, I guess, in our worlds. Okay, Mandana, sorry I went over.
No, that's okay. Thanks a lot. That was a lovely lecture. And now can I request everyone to please turn on your videos and Dr. Raghu? Yes, please take over.
Thank you, Mandana. Thank Professor for giving an excellent overview of the historical perspectives of oral precancerous lesion, taking us back to about 180 years. And it was fascinating that you highlighted some of the landmark work that has been carried out in the field of oral precancerous lesion. And it was also very interesting to note the many facets of precancerous lesions, from syphilitic glossitis to sanguinaria, leukoplakia, and also you did talk about the cocaine leukoplakia. I haven't come across any in my lifetime. And we have read your papers on the incidence rate of the oral carcinoma in situ, and the first suggestion of the use of the term smokeless tobacco keratosis, which I read and learned about it from your textbook when I was a postgraduate student in the year 1996. The first study on HPV in leukoplakia by Gree and Eversole is a defining contribution, in my opinion, in the field of oral precancerous lesion. And also thank you for clarifying some of the myths about the proliferative verrucous leukoplakia. You will have a few questions from my colleagues today on PVL. And some time back, I wrote a letter to the editor of the Indian Journal of Dental Research to rename, as you were mentioning, proliferative verrucous leukoplakia to idiopathic proliferative oral disorder, which I thought was a fancy term, iPod. I think we could discuss about that sometime later, Professor Bouquot. And I have now with me some of the eminent professors, Dr. Daftari, Dr. Hazare, Dr. Nasser, and Dr. Tilak. So if they have any questions, I would invite them first for comments and their feedback.
Before they say anything, maybe I can make a comment. I like controversy, and I think pathologists are exceptionally good at pointing out flaws in each other's research. And I think that's actually very good for the whole profession. And I should also point out that I have been saying for at least 20 years now that in the world, there are some old and staid, but really newly exciting oral pathology activities or groups. And the US and London and England have, we're part of that. We have a lot of brand new young people who are really just wanting to get into this, and us old people have retired, and there are a few spots available. However, I have said the places where oral pathology is just bubbling over in this world are India and Brazil. There's nothing, it absolutely amazes me the kind of research that comes out of your two groups, and really good research. So you're in a good place, not with COVID, but in other regards. Okay, I'll shut up.
Professor Daftari?
If I may say, I'm sorry, go ahead. I'm sorry, I apologize. If I may say something, thank you, Dr. Bouquot. This was, as always, a great review, great recap of the oral lesions. And I find PVL, or, if it's pre-named or if it stays the same, but again, reiterate, very fascinating lesion. The fascinating part about it is how it migrates from a single quadrant to a multiple, and as you watch it, and the lasering is what I find to be the best at least the best initial approach to treatment. As these lesions come on, you prove them to be part of the spectrum of PBL. As they pop in, it should be lasered, at least when they're superficial, rather than become more proliferative, quote unquote. And you chase them, but it becomes very troublesome lesion to clinicians, because it's just almost the patient get tired of the continuous follow-up and the continuous laser process. But I also find fascinating the lack of HPV association with PBL compared to the other lesions where HPV 16 and 18 contributes tremendously to a lot of the oral precancer and cancer. And I think PBL have a lot of room for still to have research in it. One comment about Dr. Silverman, I had a great pleasure to work with him in San Francisco when I was in San Francisco. And I used to go to the UCSF, his ground rounds in UCSF. And I have to give him a lot of credit for bringing up the HPV association more and more to the picture, as well as lichen planus. He was very eminent about lichen planus. And in every report I find in lichen planus, I put follow-up, all of those. And I actually started putting the erosive lichen planus patients on 3 months, and then if they're behaving 6 months, and so on and so forth. And I have some data about transformation of cancer in lichen planus. So lichen planus is a very dangerous lesion. I fully agree with you, 100%. It's one of the dangerous, quote unquote, as the lecture says, one of the dangerous lesions, and we should be following it. But again, thank you for a great presentation. Thank you.
I was just thinking as you were talking, maybe we should not use the word leukoplakia. We should follow the autism path and call it leukoplakic spectrum or leukoplakia spectrum. And then we can include all of these different entities. I think even Pinborg would like something like that. It'll never happen, but it's a suggestion.
Professor Daftari, you wanted to say something?
Yeah. Can you hear me?
Yes, we can hear you, Professor.
I may bring it to the notice of, I enjoyed the lecture. He really took us to the historical journey of leukoplakia. And it's very relevant still in these days and times, because the oral cancer is still a problem existing all over the places. So anything that we do on leukoplakia is very relevant. I might just add some of my experiences of the Indian studies that we have done, which is known as a TIFR study. And as you all know, it has been a 30 years plus study supported by NIH for a long, many years. And one of the things that I could just mention, that every study that has happened all over the world was a hospital-based studies. It's only in the Indian studies, the one which is a population-based studies. And the entire paper of birth, more than 80 pages, has been published as a single volume. I might add to the knowledge of the others, in Journal of Community Dentistry and Epidemiology, published in 1980 in Munksgaard, Copenhagen. There are a few things that I've realized over a follow-up studies of our precancer studies in the country, that there is a spontaneous regression of leukoplakia, there is a spontaneous regression of dysplasias, and all these things came out in the population-based studies. The other most important thing that I've realized is that in Indian studies, it's a punch biopsy that is the gold standard for histological understanding of the malignancy. Whichever technique we have used, including brush biopsy and well scope, we have realized that eventually we had to do a punch biopsy to get a final opinion. It's a gold standard. And punch biopsy has always been a very easy way of doing the biopsies. There's one more thing that we have realized, that in a long-term studies of almost 700 people in villages of India, the histocytological correlation is only 36%. In simple language, dysplasia and cytology correlates only 36%, and only in those cases where there's a parakeratosis present in the histology. Otherwise, cytology was never able to go beyond a certain stage into the oral mucosa. Second thing is, we did find that speckle leukoplakia was the lesion where the malignant transformation rates were very high. And the rest of the leukoplakia, like a homogeneous and ulcerated leukoplakia, were not considered that very important, but we need necessarily to follow up all the leukoplakia. Looking at the presentation, then I enjoyed it because he really took us in a long way, right from those 1800 onwards to present day. There's one more thing that I realized. I did some candida studies also in our country, in the base studies, and superimposed infection of the candida, once treated, does reduce the significant depth of the potentially malignant lesion also. So this is one stage that one should look at it, and all nodular leukoplakias may figure it out whether it's a superimposed candida or not. These are some of the salient features that I just mentioned for the time being. But I would suggest that all this information has come out because of the long follow-up. In the earlier 10-year study of a follow-up, we found only the tobacco was the factor for the cancer occurrence. It's only rare. It's only now we are finding a lot of cancers occurring de novo. And this is true even in the Western nations, that there are a lot of de novo cancers. And the location of the leukoplakias in the Western country is mainly in the floor of the mouth and in the posterior part of the tongue. So therefore, the brush biopsy and other well-scoped methods works very well because the patients are more cooperative with that. It doesn't hurt, as Dr. Bouquot said. While majority of the cancer that we find in India is buccal mucosa, and therefore we find it easier to do a punch biopsy. The locations of the cancers are so different between Southeast Asia and in the Western nation that the natural history of a cancer in the buccal mucosa is something that is, though aggressive, but still will be able to follow. While most of the cancers in the Western part of the nation are pretty aggressive, looking at the locations. So there is a difference between the cancers and two nations. And if I were to use a Rudyard Kipling's observation, whether East and West shall ever meet, the both are different. The East is different with the location of cancers because it's the alcohol and quit that gives the lesions mostly in the Western nations. But here we have a tobacco and areca nut. So whether the East and West shall ever meet or not, that's a final question you all have to decide. But I enjoyed the lecture presented by Dr. Bouquot. My compliments to him for having gone through such serious lecture presentation right from those days to this day. And I think it's a great effort. It does bring out a lot of factors, and I compliment him for all the serious studies that he has come out with. It was a pleasure listening to him. I thank you very much. And thank you for giving me the time to put my comments across. Thank you very much, Raghu, and thank you, Dr. Mandal. Thank you.
Well, I would like to personally thank you. I wasn't sure if you were that daftery or not. You don't look old enough to be the one I've read, unless there's another person with your name. I've read pretty much all of your epidemiology papers.
Professor Bouquot, there is only one and only daftery.
Okay.
Dr. Prakash Gupta.
You have done really, really excellent work. Excellent.
Professor Bouquot, we have another doyen in the field of oral pathology, Professor Hazare, who has a few of landmark work to his credit. I'll request Dr. Hazare to.
Yes, thank you, Raghu. And Prof. Jerry, I met you in 2008 during San Francisco conference. Some man introduced to me. I was to do some ECRETS fellowship with you, but it didn't materialize. Anyway, nice meeting.
Yes. Yeah.
You gave me the sponsorship letter also. I was just telling Mandana, but I couldn't make it. Maybe we'll meet in your future. Anyway, it was wonderful. And of course, I am Dr. Dastari's follower. So I am following up his comments. I am supported by his research, and I am his mentee. He's my mentor. And what a beautiful, presentation. We saw the zebras, we saw the horses, we saw the whales, and ultimately the last slide was Indian dog. Like the last canvas you showed, the advertisement of Fevicol, and there was an Indian dog, and I don't know from where you procured it. This is, what is our problem. From where did you get that last snap?
I just look all over the internet for little pictures.
Yeah.
I am retired, so I have time to do that now.
But you have been very imaginative, especially with the diagram which you gave the world during your that flight, and it was very, very, even we teach that basic diagram to all our students. Of course, they follow your textbook with the Neville also. And I was just thinking, that is Leukoplakia and submucous fibrosis. These are the two lesions, which are really, the Indians oral pathologists are concerned with. Especially I have observed that now PVL is occurring on the background of submucous fibrosis. I had 10 cases, which I am discussing with Saman. And, all of them have transferred over the period of 10 years to, overt malignancy. So that is the great problem. Of course, clinical acumen, as you have rightly said, going to help us. Red lesions and, the, suspicious eyes, like, but it has been really wonderful learning. All we have remembered the name of Shimmer and all those. And you said you coined the 39 different entities. Yes, we are aware of it. What is going to be the 40th? What 40th is going to be? You said you will disclose it.
That's the salivary chorostomas in the TMJ.
Okay.
They're actually attached to the capsule.
Yes. But so, I have been learning. In fact, your notes are with me still, which Dr. Daftari handed over to me. It's about, oral potentially malignant disorders. We have been really grateful to you for your contribution in understanding not only OPMDs, but the entire oral pathology. Thank you, Professor Raghu, for giving me then opportunity to express my, a little, understanding. And thank you so much. Thank you.
Thank you, Professor Hazare. So we have with us another legend from Sri Lanka, Dr. Tilak. And he doesn't need any introduction. He's an authority in submucous fibrosis. I think I'll have the last word for Tilak on the panel.
Thanks, Raghu. Jerry, thank you very much. It's a typical Jerry Bouquot lecture, which I'm used to listen to in so many different occasions. Jerry, now you very nicely showed us the whole history of Leukoplakia. But I want to ask you a question, actually. Now, your observations. Now, when you talk about Leukoplakia, what matters in terms of management is the degree of dysplasia. Now, you have worked on, and I think you also tried to put forward the grading system as well some time back. And we did, and a lot of people did. Now, you have seen the changes from the Pimberg and Smith photographic grading up to 2017, the last one we have, right? Yes. And also now we are in the process of doing the most recent WHO classification right now, which will be out toward the end of the year. What are your ideas? So what is your opinion on we moving from mild, moderate, severe to low risk, high risk? What is your personal view on that?
Moving from, would you say that a little louder?
Are you in agreement or you have a different issue? Sorry, I was a little away from the computer. Are you in agreement with 3-tier or 5-tier, if some people want, a dysplasia grading system over low grade, high grade system?
Oh, we're talking at a microscopic level.
Yes, micro, not clinical, yes.
Well, you have to remember, I was trained at the Mayo Clinic, and they have a 4-point grading system for every lesion on the face of the earth. You can't say something is inflamed at the Mayo Clinic. You have to say it's grade 3 inflammation. So I'm used to a 4-point system, and I've gotten used to a 3-point system. I understand where the 2-point system might be useful. Certainly there have been several studies that have shown a lack of agreement between pathologists on what is mild and what is moderate and things of that nature. And I was part of one of those studies. But I have to tell you, if people are trained in the same institution, there is good agreement. I had to, by research protocol, I had to look at all of the microscopic, over 700 microscopic examples of oral head and neck leukoplakia. And I had to look at them blind. I had an ENT pathologist looking at them also blindly. And we didn't know what the original diagnosis was. And out of that 704 cases, there were only 2 where my level of dysplasia was different from their level of dysplasia. And the same when I compared mine with the medical pathologist. So I don't think so much it's a level of how many numbers or how many levels one has. I think it's just being properly trained. And we don't really emphasize that enough, I think. But if I'm going to have levels, I'd rather have 3. I'll live with 2, and I'd love 4, but I don't know if 3 is what I'm used to. So I'll just call myself an old man and say stick with 3. I think when we came up with stages, I think we had 4 stages way back in the early 90s. But that was a Mayo Clinic influence. Did that answer your question?
Yes, yes.
Thank you, Dr. Tilak.
Short question. Now you were talking about all the entities which are now presently available and also obsolete ones. Have you seen cases of uremic stomatitis?
Yeah, 5 or 6. As a matter of fact, my first case was when I was a resident with Gorlin. He knew what it was. Dialysis had just gotten started back in the early 70s, and he had seen cases. He had faculty appointments in 4 departments in the medical school, so he was very much attuned to going over to the hospital and looking at patients. And so he recognized it, and he recognized it more from the smell than anything else. Are you assuming that that's a form of leukoplakia?
No, because you are talking about all different types of lesions that people used to call leukoplakia. But I don't know whether in the past people call that also as leukoplakia. But not during my time. I can't remember anybody calling that as leukoplakia.
Yeah, I don't think I can't remember anybody thinking that was in the same category.
Thank you,
same with
Professor
white sponge nevus and chronic cheek bite, things of that nature. Nobody's ever thought they were precancers.
I have a question for Dr. Tilak, since I got you online, and I'm fascinated by all of your publications, and I follow submucosal fibrosis with a lot of interest. Why are we not number one, why haven't this part of the world created a core center to study those lesions? Vietnam, India, Pakistan, Bangladesh. The other fascinating part that I find is, why didn't we look at the connective tissue? Why are we concentrating on the epithelium? I think there's a lot to do of the carcinogenesis in this lesion and the connective tissue, and this trauma rather than the epithelium. And this trauma is fueling that high incidence of cancer in those patients. If we know that hypertrophic scars in the skin can turn into cancers, and scleroderma and other diseases. Hypertrophic scars of the skin, always followed by dermatologists with biopsies to make sure they don't transform. I think we should probably focus on the same aspect in submucosal fibrosis. That scar, that scene, that trismus related clinical, probably has a lot to do with the carcinogenesis. We should look at probably some whole transcriptome studies, some arrays to see what is changing in this trauma, similar to ECAD hearings, changes like you see from loss of the epithelium going to the invasive potential in cancer in the epithelium, or some related to the subtypes of collagen. It will be a lot of benefit to more understanding this lesion, and I can learn from you. I know more than anybody else in this group of elite pathologists. And again, I'm clinicians, and I'm privileged to be with all of you today. But I think we should look at the connective tissue, this trauma, involvement in this and contribution to this lesion rather than the epithelium becoming malignant as a secondary reason for what's fueling that lesion compared to smokeless tobacco, which resolves. And the same histology, you can see a lot of damage in the laminar propria and smokeless tobacco, even deeper tissue, in the salivary glands. Dr. Bouquot, I think you see the salivary glands in smokeless tobacco all smudged and the collagen is lost. It's amazing how deep it is, and it goes down. So we should compare why this is resolving when you discontinue, why this continues in submucosal fibrosis rather than resolving like we see in smokeless tobacco. There's something in this trauma that's the difference between them. And it's probably a nice collaborative study with a core center in this specific region to accumulate data, to accumulate material, and do a very, very large study and comparing what the arrays shows. And that's just a humble opinion.
What's interesting that you should it's interesting that you should talk about that, because back in the early 90s, I read a paper where they looked at angiogenesis beneath a breast cancer. And that correlation was stronger than looking at the dysplasia in the cells. So I got an American Cancer Society study funding to look at that under leukoplakia. And we did find, that was presented at a national meeting, but I gave the data to a colleague of mine, and she took the data and left. But there have been people who have looked at not only angiogenesis under oral leukoplakias, but I read just last week, there's a paper on lichenoid dysplasia, and they were looking specifically at the basement membrane. Are there different chemicals in that basement membrane with dysplastic cells than there would be in lichen planus without the dysplasia? And they didn't find any difference, but people are thinking like that. And I agree. It's a wonderful concept to get together with a bunch of people and try to do all this. But I'm too old, so you're going to have to do it.
Thank you, Professor. Professor, we have some questions from the participants. So this one is from Dr. Priya Sanjeeva Rayappa. The question is, what are the alterations of the basement membrane with respect to epithelial dysplasia?
Alteration of the basement membrane with what?
Respect to epithelial dysplasia.
Oh, well, I just talked about that. There are about 5 different, I don't know if you call them proteins or cytokines or mediators that I have read about that are in the basement membrane. That's why this paper that I read last week, that's why they did their study, because of previous studies that showed that basement membrane in dysplastic cells is different. Now, it turns out when it's lichenoid dysplasia, that apparently doesn't make any difference. So that's looked at, but I don't think we use it. It's not at a practical level where we would use it in our regular path labs.
Thank you, Professor. And another question from a dean of a dental college, Dr. Srinivas Vanaki. So he wants your opinion on the lichenoid associated proliferative verrucous leukoplakia.
There's something happening here with can you speak closer to the microphone?
Dr. Srinivas Vanaki, the Dean of Dental College, wants your opinion on the lichenoid-associated proliferative verrucous leukoplakia.
Oh, yeah. And that was, I think that was a paper that came out this week, or the latest one. And that, I remember when I read that paper, I'm thinking, I bet this entity is going to eventually be called a lichenoid lesion instead of a leukoplakia lesion. They were talking not so much about PVL, but about this, what I call atypical papillary hyperplasia, the epithelium. And so I think that's a significant focus of research, really. But there again, I'm too old, so you have to do it.
So there's another question from Sushmit Koju. And the question goes like this: are the terms oral potentially malignant disorders and potentially malignant oral epithelial lesions replacing the term precancerous lesions?
Oh, no, that's, you have to remember oral pathology in the US is more or less, it may be the oldest established oral path. So we put our noses in the air, and when the Europeans try to come up with a new name, we just say, no, we're not going to use that. They did it with odontogenic keratosis, or keratosis, you might pronounce it. And they WHO tried to change that to their keratocytic tumor, keratinizing cystic tumor. And that name didn't go anywhere. It lasted about 10 years and it slowly faded away. And I don't know of anybody in my country who used it. It has nothing to do with the name. It's just, we kind of like our old names. And precancer is the terminology that I grew up with. And I understand it's not a correct term, because you could have a small cancer in there already, even though it just looks like a leukoplakia. You could have a developing one. So I understand that. But I just like, when I say precancer, it means the same. And if you can equate it to a periapical granuloma. We all know it's not a true granuloma. We all know that it's not always at the apex, and yet we call it a periapical granuloma, and everybody knows what we're talking about. So as long as we know what we're talking about, that's good enough for me.
So our last question, Professor, and this is from Dr. Osmani Guevara from Mexico, if I'm not wrong. So what's your opinion on the future therapies with photobiomodulation and immunological therapies in the treatment of precancerous lesions of the oral cavity?
Well, it just so happens that I don't have a plan of research. I never have in my life. Things just happen to me. And one of the things that happened was the photobiomodulation. And it was part of a crew, and my data was used to get FDA approval for that. So I know quite a bit about it, and I'm very happy with it. But I wrote a paper, maybe 15 years ago now, from my own experience using that technology. There are a lot of false positives. But if you know your pathology, you can look at it without the light, in regular light, and then you will see that it's that lesion. Like lichen planus is one of them. It doesn't really help with lichen planus because you have those inflammatory changes all the time. So it's always going to be a dark spot. But with regular leukoplakia, man, I am absolutely impressed with it, and have been for a long time, even though I have friends that I talk to and they say it's a bunch of garbage. And I just tell them they don't really study very hard.
Thank you, Professor. I think now I'll have to request Mandana to take over.
Thank you, Raghu, and thank you, everyone. It's been a wonderful presentation. and a wonderful discussion, which is why I have we got everyone here. And it was great. I mean, after the initial technical snafu that troubled the whole session, but the whole presentation and the discussion has been very calming and very informative and very interesting. So thanks a lot. And I think now I will just share. Yes.
बोलते नहीं.
Thank you, Professor, for a wonderful, wonderful presentation. And I hope we will have you with us again sometime soon. It's been great. What I meant to say that time that kind of got lost in all that technical problems in the beginning was that not only you're a great oral pathologist, but you're, I think I can easily say, among the kindest and the most generous oral pathologists. It was very nice of you to accept my invitation, considering we have only known each other through email. And you took the time and you have come here. I think that only says how much you love oral pathology and how much you do for oral pathology. So thanks a lot. It's been wonderful having you here.
Well, it's been my pleasure. And actually, in my retirement, I think of my role in oral pathology is to make up teaching material for everybody else to use. So it fits in. I'd be happy to help out any way I can. Next time, I will have a tooth in place.
Yes, that would be fine too. Yes, but you are perfectly fine without that tooth also. Perfectly fine. Thank you. Yes, and
Excellent.
yes, and Raghu, you can add this to your collection of your certificates from us. Thank you. I think you will need a little folder just for for these certificates.
Thank you so much, Mandana. Like how Jerry has been living up to his reputation of being Minnesota nice. I think we'll have to have a new phrase called Mandana nice.
Thank you.
Dr. Diamond, I'll just say one thing about Dr. Bouquot. Even when you were residents and we were in the academy and, we tried to learn and he's not only generous, he's the one that's, his generosity kind of equals his humbleness. He just comes to us and treats us and talk to us and teach us and extends his knowledge and expertise and material. So I told you, he's not the ordinary only oral. Beyond generosity, he's just a very unique person in our own world. I have to say this to him, and nobody appreciates him more than us. The generation that came in to match the established legends in our.
Thank you. Thank you. Those thoughts about Professor Bouquot, actually, I saw your comment on LinkedIn about him.
Thank you, Madhu.
So I think now this is around the time that I shall be, thanking all the experts. Thank you so much. Thank you, Dr. Naftali, sir, your mic is on and I think you are not listening to us. Anyway, and Dr. Tilakratne, Dr. Nasser, thank you all so much for being here, and all the viewers, of course. Now, this is the point of time. Everybody waits for what is going to be the next presentation, the next week's presentation, and I hope you are not going to be too disappointed to see this, but we are taking a little break till June. Now, we have finished 8 months, 41 videos, featured over 60 guests, and we have nearly 800 subscriptions on the channel. We have had over 16,000 views and many joining the live stream each week. And this week it was a record, almost 300 people have joined in. And it seems like a good time to say a big thanks to all of you for making it possible. So thanks a lot. And it also seems like a very good time for me to take a break. It has been fun and educational, but it has occupied almost every moment of my time. And to misquote Robert Frost, I have to say I have other promises to keep, other things to read, and other things to do. And also, I think I need to up my skill and the technology so we do not have little snafus like we had today. So I will do all that and get back to you all soon enough. In the meanwhile, I think I will be uploading new content, and there is also going to be all the previous videos you can catch up on. So keep watching, commenting, liking, and sharing the content. And if you haven't done so before, please hit the subscribe button. It will be great to cross the 800 milestone today. And yes, we have everybody here again. And thank you so much, everyone. I hope you enjoyed this as much as I enjoyed having you on the show. Thank you. Thank you, everybody.
Thank you very much. Be all,
I know.
be safe. Thank you.
Bye. Bye. And bye to all the audience. It was wonderful having you here too. Bye.